Session 3 is titled How I Do It. I'd like to request the chairperson to take the lead. I'd like to request all our speakers to stick to the speaker time duration, which is 8 minutes only. Over to you, sir.
Hi. Morning, please. Somebody asked me whether this is a permanent fixture. Sorry, guys, get used to me sitting here, I think. Thank you. Yeah. We have stalwarts in this session, carrying on from where we left off. So thank you for the previous speakers for setting it off so well. Dr. George Joseph is no stranger to anybody in this room, nationally and internationally, and we start off the session with him telling us how he does a hepatic vein recanalization.
Good day to all of you. I thank the organizers for this opportunity to present some of our work on Budd-Chiari syndrome, especially hepatic vein recanalization. We have treated 70 patients with Budd-Chiari syndrome. They're mostly young, and duration of symptoms has varied from 1 month to as many years. The etiology is idiopathic in 69%, which I call the group 1, and other conditions like prothrombotic states and veno-occlusive disease account for the remaining 31%, which I call group 2. The site of obstruction in Budd-Chiari syndrome could be in the hepatic IVC alone in 37%, the hepatic veins alone in 21%, and both the hepatic IVC and hepatic veins in 42%. And the lesions may be stenotic or occlusive. And the length of the lesions may be discrete webs which are 2 millimeter thick or 3 centimeter long occlusions. So we have both IVC and hepatic vein problems in Budd-Chiari syndrome. Here's an example of an IVC web just above the hepatic veins, which are patent but flowing into the IVC and then downwards. So this was recanalized and just balloon angioplasty done to get a good result. But often we need to stent, and this is an example of an IVC web with a total occlusion, which was balloon dilated and stented in 1998. And this result was still good 21 years later, and this is the follow-up angiogram. Now, this is the problem we more often encounter, where both the IVC and the hepatic veins are occluded, and unless we open the hepatic veins, the patient is not going to improve clinically. So here's an example where both the IVC and the right hepatic vein were recanalized and stented. So how do we recanalize these hepatic veins, which are occluded terminal, their end in the IVC? One technique is the jugular approach. So we have a right internal jugular vein access, and then we use a needle, which could be a Puckenbrough needle or a Colapinto needle, and we go through the IVC into the hepatic vein, which is patent within the liver. So we're crossing the occluded segment, and then we pass a wire down into the hepatic vein. Here's an example where the right hepatic vein was recanalized and stented to get this result on the right side. Another technique is the percutaneous transhepatic approach. Now, we developed this because the previous technique had the problem of cardiac tamponade. So when you come from transjugular approach, you may go through the pericardium and then enter the hepatic vein, and that may cause tamponade. So this is a relatively safer approach where we come percutaneously transhepatic using ultrasound guidance or carbon dioxide angiographic guidance, enter the hepatic vein, and then go on to recanalize the occluded segment and enter the IVC with a recanalizing wire, which is then exteriorized from the internal jugular vein. And then we complete the procedure from the right internal jugular vein and often put coils in the tract that we made through the percutaneous entry into the liver. And here's an example of balloon dilatation and stenting after percutaneous transhepatic recanalization of the hepatic vein. And the third approach is the collateral approach. Here's an example of a patient who had IVC obstruction, occlusion, and hepatic vein occlusion. And the yellow arrows show the patent hepatic veins within the liver. And the purple arrows show a large collateral from the IVC below the obstruction going into the hepatic vein, which is patent within the liver. So this is draining the hepatic venous system. So it's possible to go through this and then recanalize backwards, or actually it's an antegrade recanalization because that's the way the hepatic vein flows. And then you can bring the wire back into the IVC, exteriorize it, and complete the procedure with angioplasty and stenting. Now this can produce tremendous results, these techniques. Here's a child who came in a real miserable condition with severe ascites and really malnourished. And this was the problem. The hepatic veins were all occluded and the IVC had a web. So we recanalized the right hepatic vein, stented it, and also stented the IVC. And a year later, the child looks completely recovered. All the ascites is gone and she's asymptomatic. So very gratifying results when you do this procedure. What happens if the entire hepatic venous system is occluded or obliterated? So then you have to do a TIPS procedure. But the difference in this situation is we have to do it directly from the IVC into the portal venous system because the hepatic veins are not patent. So here's an example, needle passing from the IVC directly into the portal vein, and then we dilate that tract, and this intraparenchymal tract is then stented, usually with a covered stent, and this is the result that we get. So there are complications. 10% was the overall significant complication rate, mainly significant liver bleeds, but most of these can be treated conservatively. And we had 2 cardiac tamponades, which were related to the transjugular hepatic vein recanalization. And then we have thrombosis of the tips or the portal vein in prothrombotic states. The outcome was good in the idiopathic group. There was a 94% immediate success, but 27% needed repeat procedures, and then follow-up at about 2.5 years average. 83% of the patients were asymptomatic and there were no deaths. But in the group 2, which is prothrombotic states or veno-occlusive disease, initial success was less, 86%. Repeat procedures required in half of them, 52%. And then at follow-up at 19 months, only 56%, or about half, were asymptomatic. 8 had died in the follow-up period, and 6 of whom had hepatic cirrhosis. So, in conclusion, endovascular treatment is highly effective for Budd-Chiari syndrome, especially the idiopathic group. They do better. It is a less morbid alternative to open surgery, and it's important to recanalize occluded hepatic veins. If you leave them occluded and just deal with the IVC, that's not going to solve the problem. And with these current technical advances that we have, it's possible to treat most of these patients with Budd-Chiari syndrome. Very important to follow them up periodically and do repeat procedures if required, and that will improve their long-term outcomes. Thank you for your attention.
We have the discussions at the end of the session. Now I request Dr. Sandeep Agarwal, consultant vascular surgeon from Nagaram Hospital, to talk on endovascular recanalization of iliac vein and IVC in chronic venous occlusions.
This one? Good morning, everybody. Thanks to the organizer, and everybody felt very happy meeting after such a long time after the COVID era. Today, I am going to present the iliac and the IVC venoplasty. Dr. Robbie and Dr. Shekhar has, I think, made my job quite easy by explaining the use of the IVUS and showing different types of the stents. So this 37-year male, but this is quite far. There is no laptop here. Okay, 37-year male, venous ulcer over the left middle malleus since 4 months, and associated with severe pain. There is a past history of the bilateral DVT. The infrarenal IVC and the bilateral iliac vein stenting was done, and the approach was bilateral SFE percutaneous and the right IJV. So bilateral SFE were punctured, jugular approach was taken, and using the Tromo wire 035, bilateral iliac veins were crossed, and then the IVC in the serial dilatation with the different sizes of the balloon, using the 4, 5, 8, 10, then 12, made the suitable lumen, and then this was the balloon venoplasty. That is wrong. There is a significant waste you can appreciate, and then these were the different types of the stent using the Y-plasty. Vinovo, which has been discontinued now from the market. So this is the whole iliac vein up to the SFE were stented using the, and then the remolding of the stent. Now this is the final outcome of the right side. The same thing was repeated on the left side. And this is the final outcome. You can see both the SFE, iliacs and IVC. So this was the case where both the iliacs and the IVC juxtarenal was occluded. Now the second case, 32 years male, recurrent venous ulcer over the right medial malleus associated with pain and hyperpigmentation, past history of DVT with pulmonary embolism, and IVC filter in situ since 9 years. That was non-treatable filter. So what we did, the inverted Y configuration stent venoplasty of the IVC with bilateral iliac vein, approach was bilateral SFE and right IJV. And because the IVC filter was there for last 9 years, it was clogged. So what we had to do, we had to crush the IVC filter, lateralize it, and then we had to put the stent. So this was a quite difficult case because IVC filter was already there, which was non-retrievable. We had to snare the wire from the IJV approach. This was the IVC filter, Gunther tulip. This was wire passed through the filter, and little bit lumen made in the IVC. So this was snared. And the IVC filter was crushed, lateralized, and then 2 stents on both the sides were put. Whole track was balloon with the different sizes. The same thing was done on the left side. I request the organizers to give me some extra time because the third case is a very interesting case.
How much more time do you need? To,
3 minutes.
is it possible to play the, let him, yeah, okay. I think it should come up.
So the both sides were stented and there was a good flow. Please skip this and directly come on the third case. This was the third case. 30 years male, past history of the DVT in right lower limb from 2013, swelling of the right lower limb and non-healing ulcer since 3 years. The stent venoplasty of the right common iliac vein and the IVC, approach was right SFV, right IJV and less CFV. And this was done under local anesthesia. This case we did only day before yesterday. And here, if you can appreciate, the whole IVC was clogged up to the, in the suprahepatic segment also, till it was entering the right atrium. So, we had to make the lumen throughout the IVC, ballooned it, and then whole IVC we stented right from the suprahepatic vein up to the bifurcation and in the iliac vein. This was the Illuminex 16, 12, and this was the so whole track had to be stented, and this was the final outcome. Thank you very much. Thank you for giving me the extra time.
Thank you, Dr. Sandeep. Challenging cases. We'll take questions in the end. We'll now head to Dr. Danesh. I think he's also on line as a presentation on yet
At the
another
outset,
important
would like to
topic.
thank organizers of Viacon 2022. I'm going to speak on venous ulcers, many ways to skin a cat. I thought I would just talk about my approach and my philosophy of treating such patients. It's an age-old advice by many clinicians, GPs, general surgeons, orthopedic surgeons that once you have a venous ulcer, you have to live with it. For our vascular specialists, that's not really true. Many times we get these patients referred with these kind of bandages. End of the day, the therapist skill is really key and important how to put the bandages on. Sometimes you see such kind of bandages as well. My approach, clinical evaluation is most important. There's a need to take a good history and examination. Symptoms suggestive of venous pathology like old DVT or fractures of the limbs or bedridden state or any hormonal treatment in the past or pregnancy. Also need to find out whether it's a first ulceration, first time, or a recurrent ulceration. Occupation also is important to find out. Peripheral pulses examination is the key because sometimes you have arterial insufficiency, you need to decide about pressures for stockings. Of course, presence of varicosities, LDS, pigmentation, eczema, and inverted champagne bottle appearance, these are the key, whether it's a deep vein involvement. I also look for ankle disability because of long-standing ulcers causing inversion. I also find out about previous treatment, like what kind of bandages or stockings they've used and what topical drugs they have used. Duplex examination is important. Sometimes a swab if the ulcer is infected and X-ray if there's a long-standing ulcer. In duplex, I get it done from my sonologist in supine standing, rule out superficial reflux at multiple levels like SF and SP junctions or perforators in multiple positions in the leg. Course of truncal veins like the straight or tortuous. Find out also old DVT changes as well as imaging iliac veins. So when do I consider more tests? If it's a C5, C6 stage of legs, if there are recurrent ulcerations, if the adequate and correct therapy to relieve venous hypertension like compression, dressings, and superficial reflux ablation, and in spite of this, the ulcers are not healing. If it's a post-thrombotic legs or old DVT, if the severity of symptoms, heaviness or pain are not relatable to findings like few varicosities, like sometimes in young women, you might see few varicosities, but the pain and heaviness is a lot worse. It's a history of a May-Thurner syndrome. And end of the day, like every clinician would when I have a gut feeling or intuition. Which test I would ask? Definitely CT and or MR venography, sometimes both. I was imaging in many of these patients if you are heading towards iliac vein stenting at a time of stenting or before doing stenting. Ulcerous biopsy, sometimes it rule out vasculitides or even malignancies. And MRI of painful part of the legs because I have picked up local sarcomas couple of times. So if somebody has a painful leg with varicosities and ulcerations which are not corroborative, then definitely rule out some MRI of local pathology. There are different ways to skin a cat, mostly in combinations like absorbent dressings with Cutimed or Aquacel aging non-adherent. Sometimes I use back therapy as well. I would use macronized flavonoids, which are venotonic drugs, which helps venous emptying, pentoxifylline, sometimes in LDS, occasional antibiotics of local infection, and NOACs and aspirin if there is iliac vein stenting. Compression therapy, prefer ulcerative stockings over bandages. I find compliance is better. And superficial reflux like laser ablation or perforator, either using foam or laser or surgery. Then iliac veins, I was with stenting and then followed by the healing integrate or SHG. This is a combination with bandage techniques and pressure, but I use Ulcerex, which is basically one on top for 2-layer stockings. And I think it gives a better compression as compared to 4-layer bandage. The compliance is much better. And then you have superficial venous ablations like lasers, perforators with foam sclerotherapies, in May-Thurner, iliac vein stenting. It's a very classical where you have a recanalization of channels through post-thrombotic veins, and which is why you develop LDS and pigmentation post-thrombotic symptoms. IVAS is useful in iliac vein stenting. Now this is, I had an iliac vein stenting in September. Nearly took 6 months from that size of the venous ulcer to come to this size in March this year. So took almost 6 months. Close follow-up is the key. Keep an eye on ulcer size reduction. Tell patients to take weekly photos of the wound so we know how the progress is or if there's any deterioration. If poor healing, I suspect recurrence of superficial reflux somewhere else or imaging for deep veins, and if they find, treat the cause. Once ulcer heals, regular compression stockings are important to prevent any recurrence and change of pattern of job which may be possible in some of the patients. This was a study done by one of our DNB students managing venous ulcers due to superficial reflux with early intervention and compression stockings versus compression stockings alone. This is a single center observational prospective study with 84 patients and all venous ulcer due to superficial reflux with patent DVT, patent dip system were included. Exclusions were patients with secondary varicosities, mixed pathology of ulcer or pregnant females. Primary objective was time of complete ulcer healing, and secondary objective was recurrence of ulcer, rate of ulcer healing, or ulcer-free period and quality of life score. And interestingly, early intervention showed average 1.29 months of ulcer healing, whereas in conventional therapy, compression, 2.21 months to heal the ulcers. But follow-up in 2 weeks, right up to 6 months, definitely the quality of life was much better in people who had an early intervention over conventional therapy. So my learnings, compliance for compression therapy is important, and if it is poor, it definitely causes poor or slow healing. Difficult for many people to adhere to effective compressions like farmers in hot weather. Sometimes they also get pain, so they are not compliant. Elderly people find it difficult, especially with arthritis, and many of these couples have no home well, it makes it really difficult. So they prefer ulcer to pain, and which is where I think wraps could do a trick which are easier to put them on. Healing or reduction in size of ulcer develops confidence in you for further interventions like EVLG or IVUS or stent. Post-healing, regular follow-up is the key, continuing with compression therapy with stockings once the ulcers are healed. Ulcer healing is faster only if superficial reflux and ablated, but if it's a deep system intervention like deep iliac vein stenting, seems to be slower but definitive after deep vein injection. So very important to know that ulcer healing is faster if only is a superficial reflux and which is ablated. But if it's a deep vein reconstruction, it does take a longer time, but it's definitely progressive and definitely heals. I guess we still only know half why they recur in spite of best adequate acute and long-term therapy. Thank you for attention.
Thank you, Dr. Danesh. We have Dr. George Joseph and Danesh online, and Dr. Sandeep is here. So the floor is open for the next 5 to 7 minutes for discussions and questions. Ilya Kumar.
Thank you, sir. So my first question is for Dr. Sanjeev Agarwal.
Perhaps the mask off will make it clearer.
Yeah, can you hear me now? Yes. Sir, very interesting cases, excellent techniques that we have followed. But my small doubt is, for what subset of patients, particularly with PTS, like what stage of Villalta score, whether they're moderate score or severe score patients, you would take up for stenting? Because we know, as you know, the patency rate for deep in DVT induced, that is post-thrombotic iliac stenosis or occlusion, has a poor patency rate. So I saw in the second case, the patient had only edema. So class-wise, it is C3. Another question for Dr. Karmakar, sir. Sir, in your study done by your postgraduates, excellent study, that's what the Evora trial.
Ilya Kumar, I think we'll go one question at a time, please. Thank you.
Earlier, the purpose of doing the venoplasty or the stenting is not to keep the stent patent for long. The purpose to heal the ulcer then and that time, because after putting the stent or after doing the venoplasty, the ulcer healing also takes at least 3 to 6 months, and you never know the stent you have put or the venoplasty without the stenting you have done, for how much time it is going to happen. Many patients, they come, the stent is blocked within 6 months, and we have the patient where we have put the stent, the iliac stent, 5 years or 7 years back, and still it is repeated.
Thank you, Dr. Sandeep. Dr. George, question for you, sir. Edwin here. For these patients who you are stenting, what is your anticoagulation protocol?
Yeah, so during the procedure, we give a bolus of heparin, and if we do check the ACT, we keep it above 300. After the procedure, in some of these cases, we have put the patient on long-term oral anticoagulant therapy, because there is a theory that these beds and obstructions that do develop in in Budd-Chiari syndrome, it starts off with a thrombosis, which then organizes and then finally becomes a web. So, although there is no great evidence showing that giving anticoagulants prevents web formation, we do keep them on lifelong oral anticoagulation. And then because we put in a stent, we'll give one antiplatelet drug as well. Usually it's just Ecosprin. But in the first 1 month, we may give 2 antiplatelet drugs. But 2 antiplatelet drugs plus anticoagulant may be too much. So we may give clopidogrel plus anticoagulant for a month and then aspirin and anticoagulant.
Thank you, sir.
So,
Dr. Shankar and then Ilya Kumar for your second question.
so excellent cases, sir. Thank you. My question is that retrograde cannulation of that collateral vein you showed one case. How to seal that entry point after the procedure?
No, there is no entry point to seal. So this collaterals are open at both ends. One end is the IVC, the other end is the hepatic vein. So it's basically decompressing the hepatic venous system into the IVC. And so if you are able to find a collateral through which you can get a catheter into the hepatic vein, then you point it towards the IVC back again, that is higher up towards the right atrium, and then using a recanalization wire. So there are a variety of sharp recanalization wires. You pass through the occluded terminal hepatic vein and enter the hepatic IVC. And then you pass it up into the right atrium, snare it out, and complete the procedure from the right internal jugular vein. So when you finish, this collateral is just left as it is. You don't need to close it or anything. And the only place where you need to close something is when you come percutaneous transhepatic. So there you're going through the wall of the chest cage, through the liver, and then you're hitting hepatic vein inside the liver, which is patent. So that track has to be sealed off, and there we put a coil when we're taking the catheter out. But for collateral approach, nothing needs to be done. That's the beauty of it. It's it's not very invasive.
Thank you, sir.
I have
Thank
a
you, sir.
detailed query for Dr. George Joseph. Sir, good morning. This is Dr. Sandeep Agrawal. There is a tendency in the GI patient to bleed either from the upper GI or the lower GI. Even after putting the stent, if the patient have the bleeding, upper GI or lower GI, then what is your take of the anticoagulation and antiplatelet?
I'm sorry, I couldn't hear that well. Could somebody from the panel just repeat it briefly for me, please?
I think what Dr. Sandeep is asking is about the patients having GI bleeds also, sir, in these patients
Yes.
when you're doing the interventions, and your experience
Yes.
with that. Will that be a...
Yeah, so many of these patients have portal hypertension and varices, and they present with GI bleeding. And once you open out the hepatic venous system, the portal pressure also falls dramatically, and the GI bleeding stops. So it's in fact therapeutic to relieve the hepatic venous outflow obstruction in these patients with Budd-Chiari syndrome.
No, sir,
In terms of
if after
relieving
putting
portal
this-
hypertension.
If after putting this stent, even the patient has some bleeding, what do you do about the anticoagulation and antiplatelet?
Right. So then you don't give anticoagulation. You may just give aspirin alone. So if there is overt bleeding going on and you have deployed a hepatic venous stent, it's not essential that you need to anticoagulate. It's only during the procedure that you may anticoagulate. But after the procedure is over, you can stop the anticoagulation and just give aspirin alone. And if the bleeding is significant, don't give anything at all. We haven't seen acute stent thrombosis just because we stopped anticoagulation. And even the role of anticoagulation in idiopathic Budd-Chiari syndrome is not a well-defined, proven one. It is basically empirical. So there are reports saying that there's no benefit. So if you don't give anticoagulation, I don't think you're going to pay a price.
Okay, thank you, sir.
Thank you, sir. Ilya Kumar, last question. Thanks.
Sir, my question is to Dr. Danish Kamekar, sir. Sir, very interesting study that you have done by your student. As we see in those graphs, the group with compression and intervention, over a period of 6 months' time, they are almost coming together. But as we know, after 1 year, there is attenuations of these results. So both intervention group and with compression group alone. That's what the ESCA study was, the sub-analysis came about. So it will be interesting if your student can follow it up for another 1 year, the same patients whom early intervention has been done. So that will be an interesting study. Thank you, sir.
Thank you for that comment, Ilya Kumar. I think we'll bring the session to a close. And Danesh, probably you have a comment to make, Danesh, or about carrying on the study for another year on one of the arms. I think we have a link issue, so probably you could put that up in the WhatsApp group. So again, questions, speakers, please look out for queries in the WhatsApp group and answer to that. So back to you, Madam MC. And thank you, everybody. Thank you, speakers, for that wonderful session. Thank you, sir. Thank you, Danesh. Bye for now.
Sorry, Hilal Kumar, I missed that question.
Thank you.
Yeah.
Danesh, you just unmuted, I believe. Do you want to answer? Danesh? I think we'll call it quits for now and request Ilya to please have a chat with Danesh later on as well. Thank you. Thank you, everybody.
Thank you.
Thank you so much to all our speakers, our chairperson, and our panelists. We will now move ahead to our next session, but it starts at sharp 11 o'clock. We do know you've been sitting here since 8 o'clock, so we'd like to give you a breathing space. Please use the washrooms, which are towards the exit, and join us back at 11 o'clock for the Sunil Agarwal oration that is rendered by Dr. Devendra B. Dekibadhia. And this session will be compared by Ms. Sheila. And I'd like to request all of you to join us back on time so that we can abide by the time and continue the sessions accordingly. Thank you.